My name is Clotilde Panning from Illumina, and I am honored to be presenting Helene Peyro-Saint-Paul this morning. Dr. Peyro-Saint-Paul received her medical degree from Toulouse University School of Medicine in France. She completed her residency in neurology, specialized in neurogenetics. She also holds an executive MBA from iDTECT Business School in Paris. She has a large track record in developing of innovative drugs, medical education, pharmacoeconomics, and regulatory affairs, developed in international leadership positions at Serrano and Actellion. Since September 2016, Helene is part of PathoQuest, and she is the Chief Medical Officer. Thank you so much, Helene, for joining us today, and the floor is yours.
Attendees who have joined for this session. And again, our apologies for the slight delay in fixing a technical issue. So I'm very pleased to be here with you to present the project we have developed at PathoQuest, namely the iDTECT blood test. And as we will see in the next few minutes, we'll go step by step into how we have developed this metagenomic solution to try and address a medical need in the field of infectious disease diagnosis. I quickly move on my disclaimers to mention that this project has been developed independently from Illumina. And before starting to describe the project and the test itself, I would like to take a few minutes to walk you through our line of thought when we started working on this project. What we did when metagenomics started to invade, in a way, the academic labs is to look at what this tool could help us to do, and especially where it could help in a domain where the current infectious disease diagnosis tools are unsatisfactory. And in terms of medical need, we rapidly identified a specific field, which is the field of immunocompromised subjects, and where, again, the current techniques do not fully address the clinicians and the microbiologist needs. Without any doubt, I'm sure you know that these patients are susceptible to severe infections, essentially bloodstream infections, and that in more than 75% of the cases, no pathogen can be identified even after a long series of microbiological tests. The other dimension is that there is no systematic viral testing in this situation. The current battery of tests essentially focuses on bacteria and fungi. And that's an important element, as more and more papers and academic groups are identifying that viruses may be actually one of the reasons why so many patients remain bacteriologically or fungally negative. The consequences of that, this absence of pathogen identification, are very diverse. One of them, and the most immediate, is that there is a prescription of empiric and systematic broad-spectrum antibiotics. The recommendations are to start the antibiotic therapy extremely quickly, within the 1 or 2 hours post arrival of the patient to the hospital. The other consequence, immediate consequence, is that microbiologists and clinicians have a limited or delayed set of information to support their treatment strategy. The guidelines currently indicate that the treatment should be revisited within, at the end of the first 48 or 72 hours. And at that time point, again, many patients do not have any identified pathogen. These consequences in the sort of immediate time frame also have purported consequences over the long term, both from a patient perspective and from a population perspective. The group of immunocompromised patients is made of subjects treated for solid cancer or leukemia, or patients receiving chemotherapy for solid organ or hematopoietic stem cell transplantations. And for these patients, going through an episode of infection actually means potentially delaying or reducing the chemotherapy regimen, and by that potentially impacting on the long-term survival of these patients. At a broader level, at the population level, the systematic and prolonged use of broad-spectrum antibiotics actually triggers the development of antimicrobial resistance, which is, from a population perspective, one of the key threats identified by groups such as the WHO at worldwide level. So, being unable to identify a pathogen and target the antibiotherapy is a challenging situation for clinicians and microbiologists. In front of that, we have, in a way, started from a blank page with design objectives for a metagenomic infectious disease test in this category of immunocompromised patients. We started with actually 5 objectives, which are listed on this slide, and tried to set goals for ourselves in our development plan. The first objective was to be culture independent, and therefore start with a blood-based test. The second objective was to be as exhaustive and non-hypothesis driven as possible, which meant for us, of course, using NGS. Our third objective was to develop a rapid and appropriate death sequencing protocol to make sure to have a reasonably compact test. And to reach this objective, we actually targeted developing a sequencing protocol based on 150 base pair reads single-end, together with enriching the sample in pathogen nucleic acid content. From a performance perspective, optimizing detection and identification was key for us, and because of that, we decided to develop really hand-in-hand, in parallel, both the sample prep and the bio-IT pipeline. In combination, we also decided to try and address only, identify only integer pathogens, and to make sure we could monitor the performance to have a number of internal controls inserted in the sample prep protocol. And finally, in terms of time to results, we shot for a reasonably controlled period, which is 48 hours. I'm sure you know it's a quite challenging objective, but we want to achieve that because we want to return a result in the time frame which is actionable for the patients and for the clinicians. Here is what we have achieved, and I'm actually starting by the end, and we'll go backwards into more details for each of the components. We have ended up with a test, which is a sample to report metagenomic assay, starting from a blood sample with 3 main components: a sample preparation phase, which has as an objective to enrich the pathogen nucleic acids. We have patented part of the or elements of this sample preparation, which lasts 1.5 days. It is followed by a sequencing phase, which is in our current workflow overnight for a duration between 10 and 12 hours with a MySeq sequencing instrument to finally lead to the bio-IT analysis, in which we are able to generate a report in less than 15 minutes. The system is cloud-based, and I'll show you how we have optimized each of these elements to reach a clinical routine performance level. So we'll focus on the blue boxes in the next 5 to 6 minutes. And but before moving to that, I'd like to highlight that we wanted the sample preparation and sequencing steps to be run as close as possible to the patient, and because of that, we have really thought our entire process to make sure that the sample prep and sequencing phases could be run at the microbiology lab in the hospital or in the clinical center, while the bio-IT analysis would be run on our servers. Let's move now to the sample preparation phase, which is briefly described on this slide. There are 5 or 4 key steps which are described here, starting with at least 2 milliliters of whole blood. The bacteria and viruses are identified starting from 2 separate fractions, whole blood for bacteria and plasma for the viruses. And the 4 steps are namely step with nucleases treatment and detergent treatment to reduce as much as we can the RNA and DNA, free DNA and RNA content, followed by a genomic RNA DNA extraction, a reverse transcription phase to capture the viral genomic RNA, and a random amplification. At that time point, the 2 fractions are mixed to enter into the library preparation based on the classical Illumina protocols, and that leads to sequencing on the MySeq, as I mentioned earlier. The key message I would like to highlight from this entire sample prep is what you see on the little pie chart on the bottom right side of the slide, which is actually the proportion of sequencing read of microorganism origin. And as illustrated here, our preanalytical process allows to reach close to 20% of useful reads in the amount of sequences which are collected at the end of the sequencing phase. So a significantly enriched mix of sequences of reads to allow quite sensitive and specific identification of pathogens. This process, of course, has been through a number of steps of validation, and I would like to highlight 2 aspects. The first one is the validation for the different types of microorganisms. As you know, validating an NGS test is quite challenging. You cannot really do a validation for each single organism, and we have, because of that, decided to select a number of prototypical viruses or bacteria which would represent the entire landscape of these microorganisms. So we have tested all our entire pipeline on samples spiked with 5 viruses, VZV, parvovirus, BK, parainfluenza, and rotavirus, which represent DNA or RNA viruses, single or double strand, linear or circular pathogens. And for bacteria, we have selected 1 gram negative and 3 gram positive bacteria, again, that we have used for all the validation steps, analytical validation steps, to be more specific. Another spot I'd like to make on the analytical validation process is the roadmap we have followed and essentially looking at two big blocks. We ran a number of preliminary studies to be able to calibrate the plasma human nucleic acid dosage and to calibrate the internal control and pathogens to make sure our spiking experiments would be appropriate. In terms of analytical performance studies, we have focused a lot of our efforts on identifying and qualifying the limit of detection to a level where we have now reached 510 to the 3 genome copies per milliliter, and we have also run a number of reproducibility studies to make sure that the results are stable across different testing conditions. Let's now move to the second blue box on the right side, if you remember the initial slide I showed, to move to the bio-IT pipeline. And I'd like to start with a zoom on the database construction. There are a number of publicly available databases, a number of publicly available sources, but remember, our objective initially was and is actually still to have a test usable in clinical diagnosis, which means looking at human relevant infections. And because of that objective, we started by a first step, which is selecting in all these publicly available databases all the human relevant species. We did that with, and we are still doing it. We did that initially with a group of microbiology experts who screened all the databases to make their own list of these human relevant species. Moving from this list of pathogens, we then did a more in silico phase of the database construction, checking for sequence availability, looking for quasi-complete genomes, eliminating the doubtful sequences to make sure we would have a very clean database. We also looked at sequence redundancy with the objective to have a very compact database. By that I mean that to look at genus and species level, and because of the genetic drift and the variability of pathogens, more than one sequence is required. But at the same time, we should not fall into the other extreme, which is to select all the sequences available. So we did a very careful statistical and data mining exercise to reduce the number of sequences to what was needed to describe a genus and the species and the related species. And we ended this work by looking at the sensitivity of the database, meaning that by removing one sequence, we will not lose one species. And at the end of this very careful process, we ended up with a database, the iDTECT database, which we have copyrighted. The initial version was containing close to 1,200 pathogens. We are now at 1,500 viruses and bacteria, and which allow us to cover genus and species for each of the pathogens. So what does it mean in terms of performance? And to address that question, I will use elements of a poster we presented recently at ECMID, and I will first look at a comparison of the content of iDTECT with RefSec. And here we have in orange the RefSec the RefSec relevant species compared to in blue to the iDTECT relevant species. As you can see, iDTECT covers more of the human relevant species, than what can be found in RefSeq. In terms of sequences, the difference is also quite significant, and especially one on which I would like to insist, which is the number of viral sequences. As I mentioned earlier, our objective is really to cover as many species as possible for each genus, and for viruses it means trying to capture the entire genetic drift observed for in the virus world. So in terms of content, there is a difference, and which is significant. We are also very careful in updating our database regularly. On this graph, I'm showing you how the 2016 database differs from the 2017. Again, as you can see, more viruses and bacteria in the most recent database, more sequences. And there are two drivers for this increased number. The first one is that our experts are getting more efficient in reviewing the public database and literature to identify relevant human relevant species. And the number of sequences is also increasing because of the production of and identification of more sequences by all the academic teams working on this on genomics of infectious organisms. So it's very important to have a large coverage of human relevant pathogens. It's also very important to keep abreast of the scientific and genomic progress. Let's move now to the second component of our bio-IT pipeline, which is the softwares we have developed. And here again, lifted from a poster, the poster presented at ECMID. The table summarizes the comparison we have done between iDTECT and the number of available softwares which can be used for metagenomic analysis, softwares which are either commercially or publicly available. I will not comment all the columns and results, just to insist on the fact that we have analyzed in a very systematic and common way the FASTQ file generated from human blood samples spiked with 5 viruses and 4 bacteria. And as you can see on the right part of the slide, there is a quite obvious difference between the top part of the slide and the bottom one, with some of the softwares reporting a large number of viruses and bacteria, much larger than what is reported by the two last ones listed on the slide. 3 of the softwares have missed one of the viruses or one of the bacteria, and I'd like to go into a bit more detail on the last slide, which is the iDTECT results. As you can see, the 5 viruses which had been spiked have been recovered at the end of the pipeline, and 14 bacteria have been identified for 4 which were spiked, which is a very different result from all the other ones. What is important to discuss here is that we have tried to go one step further to facilitate the analysis of these reports by the user, the microbiologist mainly, and the clinician, by developing what we have called an identification confidence index. This confidence index is mainly based on 2 key features of the sequencing step, which are the genome coverage, which is obtained for each pathogen, and the distribution of this genome coverage over the entire genome. And this index, which has 3 levels, low, medium, and high, helps actually to classify the hits which are identified in the report. And as you can see in this specific experiment, for the 14 bacteria hits identified, 5 were classified in the low confidence index, which were false positives, while the 4 spiked in the sample were actually in the medium or high confidence index. So this classification really helps, we believe, in the minimization of the signal-to-noise ratio, helps also to minimize the false positive and supports a more appropriate identification of identified pathogens. And that's what we have translated. We are translating in this draft report that we have prepared, which on the left page re-explains the confidence index, and on the right side illustrates how we are reporting viruses or bacteria identified in each of the samples. So that's really how we have done the analytical validation of the test, which we have developed. Let me move now to the clinical validation, which is actually, in a way, the acid test for each assay developed. And I'll cover in this last section elements from a publication which has been recently made available in clinical microbiology and infection. I go step by step, into the design of the study. It was an observational and prospective study over 30 days, identifying viruses or bacteria with a prototype of the iDTECT test that I've described just now. An important element in the design was the existence of a clinical adjudication committee, which was responsible for identifying or determining the clinical relevance of the identified pathogens at the end of the trial, so a posteriori. The comparison was based on the identification of the number of patients with a relevant pathogen identified by the iDTECT prototype or identified by the conventional pipeline, which had very classical features, essentially based on blood cultures. 2 time points were identified for this comparison. The first one was day 1 at inclusion from the samples collected at inclusion, and the second time point for comparison was day 30 at the end of the trial. Baseline characteristics of the subjects. We selected, or the study team selected or identified 130 patients, screened them. 103 were finally included in the trial, and you have the list of reasons, nothing very specific, why they were not enrolled. 2 patients, unfortunately, had no blood samples sampled at day 1, so they were not in the per protocol analysis or intended ITT analysis. And finally, 101 patients were analyzed. In terms of subject characteristics, median age is 57, quite classical. In terms of immunocompromission reason, 1/3 of the patients were on immunosuppressive treatment for organ transplantation or hematopoietic stem cell transplantation. Another 1/3 was on chemotherapy for various types of cancer, liquid or solid. In terms of infectious disease clinical features, the site of infection was identified as potentially pulmonary in 29 patients, while 27 patients were presenting with febrile neutropenia. What did we find in this patient? What was reported on this group of patients is summarized here in the slide. And okay, sorry for that. Summarized here in that slide, which represents the primary outcome of the study. Again, comparison of the samples collected at day 1 for the prototype iDTECT versus the conventional procedures. The table gives you the number of patients with a clinically relevant pathogen, 36 for the NGS test versus 11 for the conventional procedure. A difference which is statistically significant and quite large, with a negative predictive value reaching 97%. I'd like to further describe the 2 cases which were negative for NGS while positive for the conventional pipeline. And these are 2 cases. One was a CMV case. The standard PCR test was positive, but when the site reran the same PCR test on nuclease pretreated plasma, the test became negative, and that's exactly what the NGS test is doing. We are starting from nuclease treated plasma. The second case was an Escherichia coli hit, which we decided to return negative at that time, and let me explain why. In this prototype version of the test, some of the reagents were actually produced on bacteria and with presence of bacterial DNA in the reagents. That's the reason why we decided at that time to not report the Escherichia coli hits. We have now refined our reagents list, and we are working with DNA-free reagents. We are therefore now able to report Escherichia coli hits. We also looked at day 30, which represents a much more stringent situation for the iDTECT or the prototype iDTECT test. As of course, the number of positive patients for NGS doesn't change, but the number of positive patients for the standard procedure increases, moving from 11 to 19. The difference remains significant. The NPV remains extremely high, and the difference, the 8 additional patients positive for the standard procedure are actually positive on samples collected after day 1, or on samples positive for fungi, which are not detected by the NGS-based test. Again, one important thing which I think is worth highlighting. You remember I mentioned that clinical adjudication committee reviewed all the cases at the end of the trial to decide to determine 2 things. The first one was the infectious or non-infectious origin of the clinical manifestations presented by the patients, and the second was the clinical relevance of the pathogen. In this subjects cohort, 10 patients out of 101 were actually considered retrospectively or at the end as non-infectious, and in none of these patients did the NGS test return any clinically relevant pathogen. This is clearly not the main criterion or main objective of the study, but I think it's quite an interesting finding, as we all know that NGS tests are generally report a lot of hits. In this case, with this test, the number of hits is really reduced, and that's an important observation. I'd like to finish this review of the clinical proof of concept by a table which describes the pathogens identified on the discordant cases at day one. Remind there were 27 patients discordant with an NGS positive result and a negative conventional pipeline result. As you can see on this table, the study identified, or 2 patients were identified with a virus, which was confirmed by, for one of them, by third-line PCR testing. In terms of bacteria identified, there was a quite surprising contingent of Pseudomonas. So, of course, everybody checked very carefully the origin. Most of these samples come from the same department. They were spread all over the entire study duration and testing duration. So the investigators are very confident it is not a contamination of the testing process. And then for the rest, there are a number of very classical bacteria identified. What I think is quite interesting is what I've highlighted here in the square. Again, this is what is classically considered as exploratory finding, but of quite significant interest. The investigators looked at the treatment regimen for each of these discordant cases, and in a bit more than 10 microorganisms identified, there was either no antimicrobial therapy in place or an antimicrobial therapy which was not appropriate for the pathogen. So that's a hint into the clinical utility of such a test potentially in the future in clinical practice, and this is something we will have to replicate on a broader scale and a more systematic way in our clinical development program. And this leads me to actually what we are planning to do for the clinical utility demonstration for the test. We have 2 pillars in our program. One big pillar which happens which is developed in Europe. We are a European company, so it's a bit easier. So a program called iDentify, essentially developed in France. It's going to be a multi-center study looking at the clinical and medical economic utility of iDTECT in a specific subgroup of subjects who are the febrile neutropenic patients. We are going to look at both adult and pediatric patients, and the study is planned to start before the summer. We are also in discussion with a number of other sites in 1 or 2 other countries on a similar endeavor. The other pillar is more at its initiation and will happen in the US, where we are in close contact with 2 NCCN sites, reference oncology sites, for both technical implementation, but also the collection of the first clinical data in American patients, subjects. So that's where we are today. We believe we have quite solid base to start moving into the clinical, large-scale clinical validation, and that's going to be my last slide. opening to questions. I think we have already a number of them directly. I've just put my email address on the bottom of the slide, and of course we'll be very pleased to address your comments or questions in the future.